Back to the afternoon session of the House Healthcare Committee, which this afternoon's discussion is on global commitment and our new Medicaid waiver, which is very exciting. So we have Nolan here from Legislative Council from JFO. You're a lawyer.
You see the dirty look on you?
You did.
I made a mistake last week.
Right? Numbers, letters, numbers, words.
No better.
And then we have Ashley, and I'm going to have Ashley introduce herself on Zoom with us. So Ashley, would you like to introduce yourself?
Yes. Hi, I'm Ashley Berliner. I'm the Director of Medicaid Policy. Thank you for having me.
Great. It's good to see you again on Zoom. And just real quick, I'm dealing with a very minor family situation, but I am the logistics coordinator. So I might have to step out. And if I do, whoever's here at the top of the table will happily continue the conversation. So Ashley, I apologize. I will be back as soon as I can if that happens. So anyway, we're going to kick it off to one of you.
Great. For the record, Nolan Langwell, Joint Fiscal Office, and Ashley has already introduced herself. I actually, when I was asked to do this presentation, I thought immediately that I would like to share this with Ashley for multiple reasons. One, because she is much more of an expert on global commitment. She's in the trenches. And two, it's also a great opportunity for you to get some face time with folks from AHS and see, other than commissioners and secretaries, the people behind the scenes that are doing great work. We have 2 hours today.
Well, we're on the floor at 3.
Great.
We want to give everyone about 10 minutes.
So like an hour and a half. Okay, that's good. It's a little more time than we had last time. All right, so I'll start the presentation. And so we're going to tag team this. I'll probably start off, do more of the first half, and Ashley will do more in the second half. But as always, I invite her to pipe in to correct me or fill in the blanks when I mess up. As with the presentation I gave you the other day, I kind of am trying to tell a story through the presentation. So I'll skip that slide because that's what I said. So I told you yesterday, was it yesterday or the day before? I forget.
Oh, I don't know.
I told you 16 weeks ago. So 16 weeks ago, or the last session, I was telling you that there'll be a lot of repetition. You know, some of the stuff that's in this presentation or my other presentation. I also told you that, you know, this is the joke, it's going to get really old, but if you don't get it the first time, it's not you. If you don't get it the second time, it's not you. If you don't get the 16th time, it's still not you. This stuff is really complicated. So this is part of that, trying to help you, like, not pound it into your heads because it's a violent visual, but to, you know, help you get this stuff into you the best we can. So again, this is just a pie chart of the population we're talking about. Today we're going to be focusing on the Medicaid. So that's the 24%. Because we're going to be talking about Medicaid finance, we're talking about global commitment. I'll skip this because I went through this last time. This is that visual showing you how we got more and more people on the Medicaid rolls. This one I went over this last time. I'm going to say it again because it's one of those ones that really, again, needs to be sort of reminded that, you know, the difference between Medicare and Medicaid. So Medicaid, again, is a state federal program. We'll get into the weeds of that. It's for low income. Children and adults and 65 and older, blind or disabled, where Medicare is a federal program. It's all incomes for those who are 65 or older or have end-stage renal disease, or if they're under 65 and have certain disabilities. So again, Medicare, we don't do anything with. It's not under our jurisdiction. Medicaid, we're talking about Medicaid. Medicaid was created in 1965. It's a public health benefit program for low-income individuals and families and individuals with disabilities. It's financed through a federal-state partnership and administered by the states, and we'll kind of give you a little bit more detail on that specific in a moment. And of course, the joke I gave you again, this joke never gets old. I'm telling you, it really doesn't.
Keep saying it.
I think of one joke that you tell and you're like, stop telling me, this is a joke that never gets old, because the more you understand it, the funnier it becomes.
Or the more absurd, right?
Yeah, or the more absurd it becomes. So if you've seen one Medicaid program, then you've seen one Medicaid program. each state operates its own based on broad federal guidelines, but really each of these sort of reflect the state's leadership, their priorities and their specific goals. Again, 90 million folks are on Medicaid nationwide. In Vermont, we have 208,000. I'm going to drive home this one point again about how a third of Vermonters receive some form of Medicaid. A quarter of Vermonters are actually on Medicaid, right? So we have the folks who have Medicaid relationship with Medicaid, that's 208,000. When we talk about who's on Medicaid, when I mean by on, I mean Medicaid is their primary source of insurance. That's 163,000 or about, that's the 24%. And another 45,000 have premium assistance or some form of other supplemental or partial assistance through Medicaid, but they have primary elsewhere.
How does that percentage of those totally on Medicaid compare to other states, specifically around us? Do you know?
I don't know.
You don't?
Good question. I think it would vary. It depends on the states. I mean, there's probably some states where it's hard because you can't just compare it to on and off. You have to look at their uninsured rate
Plans are
too.
different. Yeah, I get
You
it.
have to look at their uninsured rate. You also look at their Medicare rate. Like if they have an older population, or if they're a state with a younger population, it might have a lower Medicare rate or a higher uninsured rate. So you can't look at Medicaid.
You can't. Yeah.
You have to look at the whole pie chart.
I got you. Yeah.
So eligibility, and I'll invite Ashley to jump in at any point on this particular slide too. Eligibility, we talk about, when we think about Medicaid, the big things we think about are who is covered and what is covered. And, Ashley will get a little bit more into the idea of global commitment, which is the agreement, the name of the agreement between the state and the federal government. And that's an agreement about who is covered and what is covered. So essentially who is covered. So in order to qualify for Medicaid, reminder, I'm not sick. I just happened to. Okay. You have to be a Vermont resident. You have to be a U.S. citizen, permanent resident or non-citizen with lawful presence. Your financial situation can be categorized with low income or very low income and be one of the following: pregnant, responsible for an 18-year-old or younger, blind, have a disability, or a family caretaker of someone with a disability, or you're 65 and older, in which case those folks might be dual eligible. And then the benefits, what is covered, and we'll talk a little bit about what is covered. But under Medicaid, states, as I think I showed you, I think the next slide shows you, we have the stuff that is mandatory to be covered and some that are optional. Oh, I didn't put it in this one. All right. Well, if there was a slide in the other presentation, I had the optional, and the question that came up, and if you saw my email, was
Yes, thank you.
that was a list of the optional services that we actually cover, and not a list of all optional services. So now I'll kind of move into the spending piece. So again, we talked about how 24% of Vermonters are on Medicaid, or Medicaid is their primary. Medicaid spending accounts for 27% of spending in the state of Vermont. So we have our overall spending is $6.37 billion. Our Medicaid budget's $1.99 billion in 22, I think it was. And so this, we talk about Medicaid, we look at the bigger picture of the 6.3 billion, and then we focus in on 27%. Remember when we talked about the slide of the things that we control and we regulate, we're talking about Medicaid, and this is a piece that we control, is the budget. So this is a visual, this slide, I didn't create this slide, so forgive me, but essentially what this is trying to show you is what Medicaid represents as a percentage of the state budget. So the blue lines are state dollars, the orange lines are federal dollars. If you put them on top of each other, that would be the gross. But essentially, it's just this is a slide from a different expenditure presentation that JFO gives. But I put it in here because I want to show you that Medicaid is the second largest piece of the state budget. It is a huge piece of the state budget. And you can also see that it's a significant, of all the federal dollars we get in for the state budget, Medicaid is the largest piece for which we receive state dollars for. It's the second largest for what we spend state dollars on, but it has huge implications for the state budget. Again, it's a $1.9 billion budget. It's funded through a combination of both state and federal dollars. It's matching dollars. In 22, approximately 70% of all Medicaid spending in the state was through federal dollars. There's actually a bit of an uptick. We'd always talked in the past about it being 40, 60. Or there's multiple reasons for that, but essentially we think about this, the Medicaid state budget. Across all of it, 70% of that is federal dollars, 30% are state dollars. Most of it is through what we call FMAP. You're going to hear this term a lot, FMAP. You're going to hear about it when you see budget adjustment. You're going to see it when we hear about the budget. When DVA, Department of Vermont Health Access, provides its documents, they're going to have two numbers by each initiative. They're going to have a gross number and they're going to have a state dollar number. And the difference between those numbers is the FMAP. That's how more often than not that's calculated. FMAP stands for Federal Medical Assistance Percentage. We do not calculate FMAP. FMAP is calculated by the federal government. They tell us what our FMAP is. It's based on a 3-year average of state per capita personal income compared to the national average. So what's interesting about that is in the future slide, you'll see our FMAP may go up or our FMAP goes down. When the FMAP goes down, that means we have to supplement that with more state dollars to maintain just the same level of service, and vice versa. When the FMAP goes up, it means we need less state dollars to maintain the same level of service. The flip side of that is if our FMAP is going down, it's actually a sign that our per capita income has slightly increased. So it's not all bad. It's bad for the state budget, but it's a sign of underlying, there's some good things potentially happening in the economy. Now, because it's a 3-year average and there's some other factors and it's relative to other states, it's muted a little bit. But when our FMAP goes up and we're like, yay, we get more federal dollars, it's kind of a signal of something bad brewing underneath. So it's one way to something to keep in mind. Sorry.
We have a question.
Just really quickly, I wonder, how often do the feds calculate the FMAP?
Every year.
Every year?
Every year.
What time of year? No.
We know by the time we get the budget. So we get two. There's an organization called FFIS, Federal Fiscal Information for States. Thank you. You would know that. They're a very, very useful organization. We're a member and they provide all kinds of great issue briefs. One of the things they do is they calculate FMAPs for us. So they send us, usually in the middle of the summer, we get this is what we think the FMAP's going to be so we can start planning. And then it's usually finalized by October, November. So when we get the budget, we know what our FMAP's going to be. So we have plenty of, it's not always what we estimate in the estimate in summer isn't always spot on, but we're close. So we have enough notice. No state can receive less than 50% or more than 83%. So states that have high per capita incomes in general, like Connecticut and Massachusetts and those states, they're stuck at 50. They're never going to have to pay more than 50, but they're relative. They're so much stronger. Or their economies are a lot bigger than ours. But then you have states like Mississippi, which, as long as I can remember, has had the highest FMAP. They're at 77%, and that's because their per capita income is pretty low relative to other states. So, and then I think Representative.
Would it make sense to say that if the FMAP goes down, that means the state's economy is better, which would maybe mean there wouldn't be as many people on Medicaid?
So I would say because it's a 3-year average and it's relative to other states and there's some other nuances within it, I would say you can't just jump to that directly. You would say it signals that there's some positivity moving in the right direction.
Okay.
But you can't say, oh, great, this automatically means that Medicaid.
No, I mean, it's going to be what it's going to be, but because it's all based on numbers.
But I would say it's one small indicator amongst many. I wouldn't say you can look at that and draw the immediate conclusion because there's a lot of nuances and other things in it. But my point was just that it's not all bad.
No.
Or not all good. there's some other stuff that is lingering in the background. It's more of like, I wonder if there's other things happening. Let me think, like that's really more of a flag than an indicator, right? That's how I might perceive it. So in addition to the FMAP, the states are also receiving an additional 6.2% in FMAP as part of the Federal Families First Coronavirus Response Act. We are continuing to get this 6.2%. All states are getting it, as far as I know. So you would take our FMAP, which is 5675, and you'd add 6.2%. I would tell you that that's not insignificant. That translates to about $22 million per quarter, or about 80-something million dollars a year. Now, I'm going to kind of go off script a little bit, and this is where Ashley will also jump in. This 6.2% is tied to, tied to this is this idea known as maintenance of effort or maintenance of eligibility, MOE. And basically what it's saying is that when states receive this money, in return, they can't make changes to eligibility in Medicaid. But what it also means is that we can't do what's known as redeterminations. You're going to hear about this when you hear about budget adjustment. This is the biggest part of their budget adjustment. It's going to be tied to caseloads and utilization. And one of the biggest things driving that is this sense of not being able to do redeterminations in this period. What redeterminations are is basically every year, if you're on Medicaid, every year, I think on your 1 year anniversary, you're supposed to supply information about your income and your employment status, and they determine whether you continue to be eligible for Medicaid. There's a thing in the system called churn. This is a concept that will come up. And churn is this idea that there's people coming on the rolls, coming off the rolls. So there's constant churning. When you see Medicaid enrollments continue to rise during churn, it just means you have more people continue to come on than come off. But it's still this idea that some are coming on, some are coming off, some are coming on, some are coming. When the redetermination is frozen, churn ceases and people come on and nobody comes off. And so what that's doing is that increases. It doesn't mean that you're necessarily going to see the equivalent level of utilization, but people staying on the rolls will equal increased utilization. And so as a result, we're also getting 6.2% increase in FMAP to help offset. Now, one of the questions that just came up downstairs in appropriations was, are we positive or negative, right? Are we winning or losing? Are we getting more money from the 6.2 than what we would have spent in the absence of that without redeterminations? And the answer is we don't know. They don't know. We don't know. There's no way to calculate. There hasn't figured out a way to calculate because there's too many moving pieces. And frankly, honestly, DVHA is overwhelmed enough, and they have plenty of other more important things to do.
Right.
And
I mean, it's good to know, but it's not a need to know at this point.
But it's also a policy decision that I think you could probably assume that this legislator would have done regardless, because you want to make sure people have coverage. So I think.
So we have Joe and we have Leslie and we have Alan.
So we heard this morning that starting in April, redetermination is going to start again. And so I'm wondering, is that tied to, and I think we heard it was approximately a 14-month period of redetermination. I was wondering when that 14-month period is up, is the intent for the enhanced FMAP to no longer exist? Or are we still going to be keeping our enhanced FMAP as far as you know through the end of redetermination? So
this is perfect, because I was about to invite Ashley to explain what's going to be happening. And so that's exciting. So your question is, where I was going to go. So I'll let Ashley answer this question and talk about, talk about this.
I'm sorry, Ashley, real quick, can we take down the presentation while she's talking?
Yes.
So we're not just seeing a little tiny speck. There we go. Thank you.
Big Ashley on the screen there.
No.
So the federal legislature just passed, as Nolan said, kind of a disconnect, a divorce of the public health emergency from the enhanced FMAP. So starting previously, the public health emergency has been renewed something like 11 times now. And every time we were doing all this planning and then it was changing again. So they've divorced that, as Nolan said. Part of that also comes with a phased down FMAP. So it's 6.2, and then it drops a couple percentages. And then by the end of the 14 months, there's no more enhanced FMAP. The idea being that the state is over the course of months going through renewals, people are falling off the rolls. And so they don't need that full 6.2%. In reality, this is going to be an operational nightmare for every state in the country. It's unprecedented. The planning that's been happening over the last 3 years with that start, stop, public health emergency piece has been really problematic. And now we all of a sudden have 3 months to begin operationalizing it. So there's a lot of work happening at DVHA right now, and we're in the process of developing a really comprehensive communication plan. And I think getting that in front of this committee so that you're able to respond to your constituents about it will be really important. And we'd be happy to come back and really walk you through the details of what we're calling the unwind. But this is going to be the first time in 3 years that anyone has been disenrolled from the Medicaid program. So it is going to be a big deal. And we want to really make sure that we are proactive in our communication and that you all are educated on what we're doing, why we're doing it, so that you can talk to your constituents.
Okay, thank you. Yep, go ahead.
Just, do you know what the drop dead date is for EFMAP, where, it will then fully be reverted to standard FMAP?
I can get you that schedule.
Okay, thanks.
We have Leslie. Okay, Leslie, and then
I
Ryan.
just wanted to verify, you said that the increase in the FMAP for a whole year was 84 million? Did I get that right?
It's about 22 million-ish per quarter.
Okay, so 86 million. I just
Yeah.
never knew that and I was wondering, thank you.
I mean, it's ballpark in there. I don't know the exact number, but it's in that.
Is that how the money comes in quarterly?
No, we're counting it because the public health emergency is renewed quarterly. So so each quarter, okay, there's another 20.
Yeah.
But it's not that perfect.
Brian, sorry, did you have a
Oh, no.
Okay, Brian.
So I might have missed it, and I was looking back at the presentation and didn't see it, but do we have an estimate of how many people are going to be affected? And in addition to that, do we know what they would qualify for after being, trying to think of a nice word, removed from Medicaid, in terms of other programs available through the exchange? So in other words, the number of people impacted and where they might fall in terms of other benefits they might receive in terms of tax breaks and stuff through programs through the exchange.
Yes. So we are aware of about 29,000 people.
How much?
29,000
Okay, thank you.
who are at some point over the last 3 years, because we've been running things in the background, have had information sent to the state determining them ineligible. And so we assume that those 29,000 will drop off immediately. Everyone who is disenrolled will be noticed twice, saying, this is the information we have that says you're uneligible. Please send additional information if you believe this is incorrect or if it has changed. They'll then be noticed again that they are losing coverage. Everyone has appeal rights and so can challenge that coverage and will have continuing benefits during that appeal decision if they believe that we've done something, made something based on bad information. And then everyone will be steered towards applying for a qualified health plan who is disenrolled from Medicaid. And at that point, they'll be screened for eligibility for premium assistance and be able to go through that process on the exchange. But again, I think getting back to you with a really detailed roadmap from the experts on the unwind will be really important. So the 29,000 are kind of the known entities. There are a lot of people where we really don't have any idea. So we anticipate that is going to be bigger than that. It's going to be bigger than that number. But those are just the people we know right now. And it is not going to be day one, we're renewing every single person on the Medicaid roster and we'll have good information after that. It's going to be, tiered out month to month where we're reviewing X number of cases each month. on a schedule because we just literally don't have the resources to renew everyone all at the same time. So we're going to be kind of stacking that, and we'll be starting with folks that we think are ineligible and cascading down from there. And again, I think the operational experts on the unwind will be able to walk through that in much more detail.
Great, good.
So it sounds like you can't give us a number. You can't estimate who will fall where because we don't know where people are at. And until you have that information, we don't know. So that's fair. And it sounds like about 5% of Vermonters are on Medicaid because 29,000, if we just round it up to 30,000 and say 600,000, I know that's simplifying.
29,000 are the numbers on Medicaid that they know.
That's what I mean. 20,
Okay.
So yeah, I said it wrong. So there's about 5% of Vermonters we expect to be immediately impacted. The question I have is how many people are on Medicaid total? That's what
180.
Earlier slide, 208,000 on Medicaid, and of which 100 and you can look at 160 something thousand, I don't know off the top of my head, have as primary. It's an earlier slide.
24%.
Yeah, I can pull it back up, but then you lose Ashley.
Yeah. Okay, let's go.
All right, I can pull it back up.
I'm looking back too.
Yeah, it's on that previous slide.
It's 208,000 Vermonters approximately receive some form of assistance through Medicaid. 163,000, it was their primary source of coverage, and 45 was supplemental.
So 163,000. All right.
I'm going to ask a question of something that Alyssa's whispering in my ear, because I remember at some time when I was here, we did this, I think. Oh, I know what it was. It was over the individual mandate where Nolan, you may remember, Ashley, we attempted to have the tax department be able to give information to DEVA or vice versa. So the overall question is the tax department can't help us in this situation because they don't share information. Is that accurate?
Defer to the executive branch on that.
Okay.
I don't know exactly.
Actually, we can't hear you.
You can't hear me?
Oh, now we
Right
can.
now.
Now we can.
Okay. I don't know exactly. We certainly aren't getting the tax information directly to be able to run queries on income in terms of being able to access the data in real time. I don't know what other data constraints exist that make it impossible for us to know, other than we literally haven't been asking people for this information. So some of this is just, we haven't asked and they haven't told us.
Right. Okay. Thank you.
Okay, now we're going to move back into the presentation. This is a side note. So we have three kinds of FMAP. Well, there's multiple FMAPs, right? We have our regular FMAP, we also have an enhanced FMAP for our children's health insurance program. If you recall, that's a subset of the folks of kids in Dr. Dinosaur. That's about 4,700 kids. And then we have another enhanced FMAP for childless new adults. And we talked a little bit. Did we talk with that?
Yeah, we talked about this. Yep.
So our regular FMAP, which is the majority of our Medicaid folks, that's 56.52 federal, 43.48 state. So one way to look at it is for every dollar we spend, 43.48 cents is state dollars and 56.52 is federal dollars. Or another way to look at it is for every dollar we spend, it grosses up to $2.30 in program. So state dollar is $1, federal match would be $1.30. It would equal $2.30 in services. Now, one thing I used to have to tell people when we were in not as good financial times, and this committee was tasked with finding places to cut services, we had to say, well, great, for every dollar we spend, we get $2.30 in service. But every dollar we cut, we lose $2.30 in service. So it's a double-edged sword. So for our children's program, it's roughly, for the CHIP program, it's roughly a 70-30 match. And for our childless new adults, which is about 47,000 folks, we get a 90-10 match on those folks. So that's for every dollar we spend, we get $10 in services. So we save we get a lot of savings on those folks.
With the enhanced FMAP, the 6 point whatever, So that's not included in these numbers.
Correct.
And is it included in these enhanced FMAP? So are we getting 96 point?
No, so
something?
my understanding, and Ashley can correct me, is that it's embedded in how it's calculated. So it's not a clean 6.2, but it's embedded in there so that it does affect it, but not, like you can add it to the 43, or you can add it to the 56.52 and get a clean number. But for the other two, there's a formula,
Okay.
and I believe it's embedded. Although I think for the 90-10, again, I'll ask Ashley to correct me on this, I don't think it affects that population either. Ashley?
Yeah, I'm not sure about the childless
Oh.
results, but we can talk
Can't
about
hear you,
it.
Ashley.
I'm
like a
not
delay.
on mute. I'm not on mute.
Oh, there's like a
Can you hear me?
delay when you first start speaking and then
There's
it
a
works.
delay. Okay, I'll keep that in mind. I am not sure about the childless adults. I think you're right, Nolan, but we can connect with AHS Finance on the specifics of that. It's definitely true that the 56.52, you just add the 6.2 on top of that, but I'm not sure about the enhanced FMAP, so we can look into that.
Yeah, if I recall, yeah, we'll look into it. So this is meant to sort of show, and I talked about, we get it every year, we learn if it's up or it's down. If it's shaded, that's years where the FMAP has decreased. And if it's white, it's years when the FMAP has increased. So this kind of just shows you kind of like this flowing trend. And it's interesting because at one point I had a different piece that was trying to compare it to recessions. And there was sort of a trend earlier on. You can also see that when things also happened, like, we had our temporary relief for states, which was, and why was there temporary relief for states? Because there's something happening in the economy. We have our ARA, which was our American Recovery and Reinvestment Act. Again, it was happening at a time, that legislation happened because we were in a recession or there was economic downturn. And so you can see that there seems to be a relationship in some of those. And then we have the Affordable Care Act. But these are the base FMAPs. And so you can just see there's like this ebb and flow over time. So that's really what just the story I wanted to tell there.
Joe?
I'm trying to think how to phrase this question exactly. So we're looking at, let's say, 2019. So in 2019, which was before the FMAP bump, our state share was 46.21%. In 2020, it's 46.13%. Is that 46.13% inclusive of the bump or?
No, these are not including those. These
Okay,
are base.
cool. Great.
These are base, not including bump.
Wonderful. And so that's my question. Thank you.
Okay. All right, I'm going to pass the torch to Ashley here to talk about global commitment. And just like, tell me when you want me to change slides.
Will do. Can you guys hear me?
Yes.
So the global commitment to health demonstration waiver is an 1115 waiver, which is a policy tool that the Centers for Medicare and Medicaid Services uses to allow state Medicaid programs to innovate and test changes to the Medicaid program to see if they can increase access, decrease costs, increase quality. Vermont's
Ashley, I'm sorry, you're kind of going in and out a little bit. I don't know.
It's a little echoey. It looks like she just moved, right?
She's gonna.
So you put a headset in.
Give me a second here, I'm sorry.
Okay, no worries. Thank you.
Hope it's sticking.
Pause up a quick thing.
Can you hear me?
Nice snow globe.
Yeah, that's wonderful.
We can hear you.
We can hear you. It's glitchy. It was.
Okay, 1 second. I'm so sorry.
No, take your time.
In the meantime, what are those?
Oh, maple pretzels.
Wait, these?
Yeah.
Maple pretzels.
Buddy, my mind was drifting to those too.
We're still on YouTube. We're still live.
So we've been, I'll ask, just because I'm really interested in that previous slide about how it's going. So basically, since 2000, our state share has been increasing, and that seems to just be the trends that we're in. And is that trend, do we have any idea of why that trend is? Are we seeing increased income in the state? Is that due to, I know you said it's a comparison with other states, so I guess the answer is we are doing better fiscally than other states, but is that due to us going up or other states going down? Do we have any idea of what those trends are? It's just too complicated for us to figure that out.
I don't know the answer to that. If you're interested, what I can share with you is the most recent FFIS document that explains the current FMAP, because they kind of have more of an in-depth piece of like, here's what other states are doing and here's what happened. I'll send it to you because I think you'd nerd out on it with me.
Yeah, I'd like to take a look at that because it's just interesting to me to think about, why are we on an upward trend with our state share? And the reason I think about that is because of, if we're doing better, then that means we have more revenue coming in, and that means that it shouldn't be as much of an impact. But if it's just that other states are doing worse, then our revenues are flat, but our share increases, thus causing us to have a greater burden on the state.
There's a lot of, like I said, it's nuanced. There's a lot of other factors that go into it. So I don't know that you can pinpoint this and like, great, we're just doing better. I will point out that if you look at our 2024, we are moving back into, 2012, 2013 territory.
Yeah.
So in which case it's just, you can look at it as long-term cyclical, but.
Yeah, exactly. I also wonder if it's possible to do a comparison of it with gross receipts in the state budget or something like that, just to see.
I don't think you can do apples to apples.
Okay.
I really don't think it's.
Okay.
Ashley, are you ready yet?
We have one other question, Alyssa and then Leslie. And Ashley, just jump on when you're ready.
I can't believe how many 101 questions I had the second time around that who sets the eligibility, like the federal poverty limits? Where is that set?
That's set by the feds.
Set by the feds. But lots of different states have lots of different levels?
Everybody has the same everybody uses the same federal poverty chart.
Yes, but I'm saying the eligibility to receive Medicaid. I mean, because.
So if you see one Medicaid program, you see.
Highly.
Yes, how does Vermont, in the state of Vermont, who sets our eligibility guidelines of who's going to be eligible and who's not?
So I'll turn it over to Ashley for global commitment.
Okay, wait, I'm sorry. Ashley, I'm sorry. Wait, I just want to. So there were a couple questions. Are we good to move on and we can come back?
I have one question. You didn't.
Okay, go ahead.
Idiotic. What's a new adult?
New adult is the name of. So we have this thing called Medicaid eligibility groups, and it's a back end term, but essentially. That's the expansion population under the Affordable Care Act. Those are the people that were not traditionally covered by Medicaid. And then the Affordable Care Act came through and expanded Medicaid. And these are the groups of people that were not have been covered prior are now covered.
Okay, so it's not people who turned 26 or it's not refugees. That's what I was trying to.
New is a terrible term.
Yeah.
It's an internal term, but we keep using it. It's an adult expansion population. It was new at the time.
Okay, not new anymore.
Yeah.
Okay, let's get back to global commitment. Thank you, Ashley.
Okay, and sorry for the IT challenges here with the sound.
60s, right?
So just really quickly, I wanted to follow up and say that on the enhanced FMAP, it is 6.2% on top of CHIP, but not 6.2% on top of the new adults. So just to follow up there. And happy to address the question about eligibility thresholds now or later.
Let's do it now. That'd be great.
Okay. So there are categories of Medicaid eligibility in federal law. So the Affordable Care Act actually expanded Medicaid access up to 138% federal poverty level in 2014 for the first time. Previous to the Affordable Care Act, the only way you could get into Medicaid is through something we call category, which means you're aged 65 and older, disabled through the Social Security disability determination process, or a parent, caretaker, relative living below the poverty line. And there were federal poverty levels codified into law about what those thresholds are, and they're different depending on which category you fall in. The Affordable Care Act established this new adult group, as Nolan just said, and it went up to 138% of the federal poverty level. That's a state option. Vermont took that option. And so those are kind of set in stone. The things where there's a lot of discretion around are 317% FPL for children, 211 FPL, 215 FPL for pregnant women. Those are things that Vermont has historically pushed the envelope on using instruments like an 1115 waiver. And we've been able to establish that now historically through global commitment and other mechanisms. And it's now in a place where we're at a maintenance of effort requirement and we can't actually go below those thresholds. So, over the decades, the legislature, the administration has determined that children up to 317% FPL are going to be eligible for CHIP. And now we're kind of stuck there. We can't go lower, we can't go higher because of decisions made at the federal level. We have very little discretion today around the FPL limits.
So we've negotiated this in the global commitment and we're stuck with it and we have to stick with it.
The floor, we are, yes, the only area where we have any ability to change our income thresholds is for pregnant women. We could go down below 208. Everything else, we're in a maintenance of effort where we are not allowed to reduce our Medicaid eligibility thresholds for kids, for new adults, for parent, caretaker, relatives. It's just like, it's what we adopted and that's where we are. We always, push on administrations at the federal level to expand access. We don't usually have conversations with them about reducing access.
I can also just sort of flag that we only have about 15 minutes and we would like to try to get through all the slides. So
I appreciate that.
you can just keep that in mind when you're asking questions.
Sure.
I agree. Let's go, Ashley.
Okay, let's try to speed through here. The 1115 Global Commitment Waiver is the mechanism that we use to administer our entire Medicaid program in the state of Vermont. So Scene 1 Medicaid program, that is particularly true in the state of Vermont. CMS calls us a unicorn. I think that is apt. We are one of 3 or 4 states in the country that don't use private managed care. And we are the only state in the country that operates our entire Medicaid program under an 1115 demonstration waiver. And what an 1115 demonstration waiver does is it explicitly allows you to waive federal law in administering the Medicaid program in order to push forward on innovation, quality, cost control. The main through line for all 1115 waivers is that it must be budget neutral. So you can never spend more with a waiver than you would have spent without a waiver. Other than that, it's really a tool that the Centers for Medicare and Medicaid Services, CMS, uses to push innovation and use states as kind of incubators of Medicaid policy reform. Next slide. So, as I said, many states have 1115 waivers. We're the only one where it's comprehensive. And in Vermont, we've had it since 2005, and it's continued to evolve and expand. We really use this waiver in 2 ways. It provides us additional money for populations and services that we otherwise couldn't use Medicaid to pay for. And it gives us additional flexibility to administer our program in ways that we would not be able to do if we were following federal regulation. And so there's a list of it here. I can go through them if you want in the interest of time. I don't know if you want to just review this at a later date, or if you want me to walk through these, or if you have specific questions.
Yep. So Ashley, I would just say I want to confirm that. So now we're talking about the global commitment that we recently signed, correct? So this is a new 5-year global commitment, or I forget how long.
Yes, thank you. So we renewed our global commitment waiver in July of 2022, and it is a 5.5 year because we had COVID extension. So we ended up in kind of a weird period, and it goes through the end of calendar year 2027.
Great. And I think what I'm going to say is let's tag this slide to come back to if we have time today. And if not, we will definitely cover some of this stuff in the future.
Okay, great. Next slide. All right. This is one of my favorite slides. It's similar to the previous slide in terms of that first thing, what money do we get for services and eligibility groups, but a little bit more of a visual expression. And so if you look at the top teal box there, that is your comprehensive Medicaid healthcare benefit. Your kind of bread and butter, go to the hospital, go to the doctor, pharmacy benefit. And these 6 groups here, age, blind, disabled, pregnant women, new adults, children under 19, working disabled, and Katie Beckett, are all what we call state plan eligibility groups. They have full Medicaid coverage. Under that, you have your home and community-based services for designated state plan populations. So these are choices for care, your developmental disability services through DAIL, mental health services for children, and brain injury services. And so these folks in purple receive all of those really comprehensive health insurance benefits under the state plan. So same as the teal group above, but they also receive a really robust home and community-based package of support and services because they are determined disabled, and it is an alternative to long-term institutionalization. And so
if I could just, sorry, go ahead, Ashley.
I'm going to say this is things like supportive employment, comprehensive case management, respite, support with activities of daily living, just as an example.
And I would just say, again, to help understand the jurisdiction between us and House Human Services, this purple section mostly is the policy jurisdiction of Human Services. We have one question, Joe.
So I'm just curious, because if I'm trying to understand if I'm reading the slide correctly and therefore understanding the program correctly. So you can't get Medicaid just for being of low or very low income. You have to also be either age blind or disabled, pregnant, a new adult, which I'm not fully understanding what that is, a child under 19, working disabled, or a disabled child under 19 without getting the income. So like just not having being of low income isn't enough.
That's what the new adult group is. So prior to the Affordable Care Act, it wasn't enough. Under the Affordable Care Act, they said, if you're low income, you don't have to fit in the category. We're just going to expand Medicaid to allow you. So that's what the new adult group is. It's basically doesn't fit in any other category besides income.
So in my head, I should put a red line through the new thing there and just consider the adults at or below. Great. Okay, thank you.
The word new is a relic because it was new once.
Right, yeah.
But we haven't taken the word new off of it.
Got it. Thanks.
And it's a back end term, really.
Yeah, and new as in previously ineligible adults. Yeah.
Yeah.
Okay,
So
thank you.
Those top 2 buckets, the teal and the purple, are populations and the services that they receive would be available without a waiver. So we wouldn't need the 1115 waiver to provide those services to those populations. How we provide those services, we do leverage our waiver. The bottom set of boxes where you see with waiver only in kind of a red outline, we can only pay for these services and people because of our 1115 waiver. And that's the BFARM program, which is comprehensive pharmacy coverage for elderly Vermonters at income under 225% FPL. It's the moderate needs group. So individuals who are not clinically eligible for home and community-based services because they don't meet that institutional level of care, but they're at risk for institutional level of care. And so we really want to be proactive in preventing them becoming more needy and needing that institution. Community rehabilitation and treatment, which is administered through the Department of Mental Health. And that is for individuals with chronic mental health illness, regardless of income. And that is a new feature of our waiver. It previously was capped at 185% FPL, and we waived that income limit first state in the country to be able to offer Medicaid services without regard to income. And then the last box in that kind of going some weird form of clockwise is marketplace subsidy program. And that is individuals purchasing health insurance on the exchange, receiving premium subsidies to buy their private insurance.
Sorry, Ashley, just a quick question. If we wanted some more information on how the community rehabilitation treatment is happening now with the new waiver, would we go to DMH for that, or is that through DVA?
If it is programmatic, it is going to be through DMH. They administer the program. Yep.
Great, thank you.
Great question. And I did try to include the departments here so that
Yes.
you do have a good sense. DVA is the payer, but the Medicaid program is really across all 6 departments at the Agency of Human Services, and we kind of own different program areas. So yes, please go to DMH for any CRT questions. And they also administer the kids' mental health benefit.
Yes.
And real quick, and Ashley, correct me if this statement is wrong, but if we did not have a waiver or global commitment or anything, everything in that red box below would not exist and or would be pure state dollars.
That's right.
Okay, thank you. Daisy?
Benefits.
I don't know if we have time for you to get into this, Ashley, but I'm really curious if you can explain maybe some of what the waiver renewal did that was more innovative than what our previous one did.
Can I just, let's say real quick too, I have an issue brief on this too.
Great,
And I'll send it
yes,
to
for that.
Please do.
So it can get into the weeds, but go ahead, Ashley, sorry.
Yeah, definitely, Daisy. And I think the administration would love to come speak specifically about the new waiver at any point. I think we were trying to just, as an initial introduction, be what is it, but happy to come back and talk about the changes. We're pretty excited about it at the agency. In the orange box here, this is the things that are not population specific that we can pay for because of our waiver. If we didn't have the waiver, it'd be general fund or we wouldn't do it. And that's a list of about 80 investments, which we have a link to in this deck. It's anything from paying for 211 services to providing federal funding to the public health lab to paying for uninsured, underinsured emergency mental health services. So it really runs the gamut. Like I said, there are 80 of them. We're going over the next 5.5 years to 5 years now, really go through those and put them through a pretty rigorous evaluation process to make sure that it's moving the needles in the way that we want them to, that we're actually getting results in terms of the goals that were set out for those. A lot of these 80 investments were established in 2005, don't have a lot of quantitative measures behind them. And we want to understand, is this actually doing something to increase access, decrease cost, or improve quality? And if it is it scalable? And if it's not, can we pivot and put that money to better use somewhere else? So that's a pretty big initiative that we're going through right now. We're actively in procurement to get what we hope is a really substantial independent evaluator to do some of this work with us, and look forward to being able to report back on some of the investment conversations at a later date. The other cool thing about the new waiver is, for the first time since I have been in Medicaid, which has been since 2012, we are actually doing new investments. So we did get a lot of flexibility under the new waiver to make new investments for the first time in a long time. And we're starting to take advantage of that in a way that we haven't been able to for a long time. So that's pretty exciting. We also are able to make IMD payments, Institution for Mental Disease, which is a specific federal term for a medical facility that primarily serves patients with severe mental illness or substance use disorders that is over 16 beds. And in Vermont, that's Brattleboro Retreat. It's the Vermont Psychiatric Care Hospital, Lund Home, Valley Vista, and several of the other residential substance use programs out there. We also are able to pay for cost-effective alternatives using this waiver. So something that Medicaid doesn't traditionally pay for, but it is a cost-effective alternative to something that Medicaid pays for, we can start to use that authority. This isn't something we've leveraged before, it's new. And so we're still exploring how to best optimize this flexibility. But an example that I think about is we don't cover acupuncture, but acupuncture could potentially be a cost-effective alternative to a more expensive surgery, for instance. So that's kind of the way that we're trying to think about how do we leverage that new flexibility. And then palliative care for under 21. This is a set of services available regardless of income for children at end of life, so that them and their families can receive palliative care through the Department of Health.
And Ashley, I apologize, I stepped out for a moment, but I just wanted to say I'm thrilled to hear that Divas and probably partners are going through the investments. We've been given the list, year after year of all the investments and really no background as to how it's working. So I'm thrilled for that. And I'm sure it will take a long time, but hope throughout the process, someone will come back and just update us on where things are and how maybe we're moving dollars into different programs or really how the programs are working. So thank you for that. Leslie had a question.
Yeah, I'm not sure this question is worth answering now, but what I'm struck by is that it must be budget neutral to the federal government. So we have one pie. And if we're moving all this money over to these things, what are we not doing that we would have been doing otherwise? Or is that not relevant?
No, it's completely relevant. I'm sorry.
Go ahead, Ashley.
It's very relevant. And the premise really is that second part. So we get money we wouldn't have otherwise gotten for our waiver. And we also get flexibility we wouldn't have otherwise get through our waiver by administering the Medicaid program more flexibly, which is kind of a abstract concept. And I'll try to get into some examples. We're actually able to reduce costs in our core Medicaid program. So those first two, like the teal and purple, those first two groups without waiver, we're able to reduce those costs and then use the savings to spend on other things. So for example, the home and community-based services, those purple category, those folks are all eligible for nursing facilities. Because we use a really widespread home and community-based system of care in Vermont, and we're really focused on community care rather than institutional care, we're able to spend a lot less on those individuals than we would if we were just putting them in a nursing facility. And so the dollars that we're saving, hypothetically saving, because none of this is real, we're able to invest in other initiatives that are public health focused and help with access and quality and reduced cost. And that hypothetical nature of all of this is really key too. Budget neutrality at the federal level is fake math. It is a really abstract and obscure calculation that is not transparent at all. And it becomes a game when you negotiate like how things exist, what they would have cost hypothetically. It's a real interesting art to get to your budget neutrality calculation. And so it's not always the most logical equation.
Thank you.
So the history of global commitment when it first passed or became a thing years and years ago was that it was supposed to be sort of a public managed care like entity. And, the concepts behind managed care are that if you manage your population and can make them healthier, the achieved savings are profit. But under the model at the time, those achieved savings we could reinvest into these kind of things. We've moved away from that sort of concept of that terminology, but the concept remains the same. We're managing a population and we're achieving savings. But how you measure that is where the negotiating the numbers, or as Ashley called it, fake math, is because at this point, we've been doing it for so long. We don't know what the spending would have been in the absence of the waiver. So that the savings and that cap, because the global commitment has a cap, becomes a negotiated piece.
Art?
We're getting close too, so
I know.
we have a couple more slides.
Yep. Go ahead, Art.
And this is quick and probably a really stupid question, but I'm looking at slide seven.
I'm sorry. I just want to stop and I want to remind everyone, there are no stupid questions.
know.
Let's take that out.
Rather than asking this
Let's take
question.
that out of our
Put it up there.
Oh, okay, I'm sorry,
Put it
but
up in the print screen. No stupid questions.
I'm on slide 17, the global commitment to health. The first bullet, and this is just a terminology thing. When I say you used to administer the majority of the program, when I hear administer, I hear, it means to me that you're running the program. Does that include the money for the program?
Yeah.
Yes.
Okay. It's just a term that includes paying for the program.
Yes. So this.
Okay, administering it and paying for it.
Yes.
Okay. It's just that,
Everything
that's
is
all I
done
want to
through
know.
DEVA.
Because when I see administer, it doesn't mean paying for it.
Yeah, it's
That's different here. Okay, got it.
Okay, Ashley.
See?
Okay.
Oh,
So we can go over this slide quickly, but basically, just to restate the goals, it's really about transforming health, increasing access, improving quality, and decreasing cost. And everything that we're doing under this waiver is with those aims. We really are focused on population-wide coverage. This current waiver is also really interested in addressing social determinants of health, and we've gotten a lot of flexibility in this waiver to be able to do that. And we've also committed to acceleration of payment reform, particularly in the all-payer space and home and community-based services. So we can go to the next slide. I think you were just getting at this a little bit, Nolan, but under this waiver, one of the ways that we administer the program differently is DEVA operates as a managed care-like model. So as I said, I think about 47 states operate their program through private managed care. They might contract, California contracts with a Kaiser Permanente, for example. Some states have like 45 managed care contracts, some have 1, some have 5. It runs the gamut across the country. Vermont, instead of contracting with a Kaiser or an Aetna, contracts with DEVA. We're the only public managed care-like model in the country. And that allows us to take advantage of managed care regulations, which are a lot more flexible than fee-for-service regulations when a state is directly paying for a Medicaid service. So Connecticut doesn't have managed care. They have to follow fee-for-service federal regulations, and they have very little ability to pay for things that aren't strictly outlined in the Social Security Act. And so this is a really key concept of our global commitment to health waiver, is this administrative structure, so that we get the flexibility and we get the money to pay for those things that were in the previous slides. That link there is the list of the 80 investments for you to explore, and we're also really excited to be able to come back at a later date once we've gotten this evaluator and talk more about that work.
Great, thank you.
Just wear your glasses, because it's like 1 point.
It's really small.
Next slide. Just a visual of what I just said. So the Secretary's office plays the role of single state Medicaid agency. So they are actually, from CMS's perspective, the Medicaid program. And then AHS contracts through an intergovernmental agreement with DEVA to be the public managed care entity. DEVA then subcontracts with other departments, including the Agency of Education, beyond the AHS departments, to carry out different components of the Medicaid program. So DMH has the mental health programs. The Department of Health has the Division of Drug and Substance Use. AOE has special ed, Dale has adult services and developmental disabilities, and DCF has lots of residential programs for children, case management services, and children's integrated services.
So when you get the budget, and you're going to get these spreadsheets, and it's going to have like the program on the side, and you'll see like the different funds. You'll see, so you might get, when you get the DMH budget, you'll see that there's general fund, there's federal funds, and you're going to see global commitment. And you'll see that's the part where that particular program in the mental health or mental or other agencies are being run through global commitment and getting matched.
I think that might be the last slide, is that right?
Yeah, just our FPL chart.
Okay.
Oh, we have plenty of time for questions.
Well, okay. We just want to make, we didn't
Yes.
do it all in appropriations yesterday. I wanted to make sure we.
So can we go back, since we have time, can we go back to slide 18? And just talk about some of is that the one
That's the one you put a flag in.
yeah. And I think one of the ones I would love to hear more on, make sure that it's early stages, but I know one of the ones that people were pretty excited about was this permanent supportive housing services. So Ashley, I know it's very early stages, but if you have any information you can share, and if not, we can wait.
Yeah, I have limited information I can share because it is so early. But as you'll see, the substance use disorder coverage right above that and permanent supportive housing, there's a typo there, are two new packages that we got through our waiver negotiation. So got authorized in 2022. And we are working through both of them. Permanent supportive housing, we're trying to be really aggressive about because we know that there is such an intense housing need. The substance use coverage is actually an expansion of coverage for individuals above income, similar to the mental health CRT wrap. And we're slating that to be 2025. We're trying to get permanent supportive housing done sooner. So where we are on permanent supportive housing, it will only be in the initial stages available to that purple group. So folks who are already eligible for home and community-based services, either because they're disabled, have a serious mental illness, or are at institutional level of care, like long-term care need, brain injury need. So right now, out of the gate, we're limiting it to that population of home and community-based services. Where we are today is in the process internally of drafting an RFP, request for proposals, to get national experts who can marry the really complex Medicaid policy space with the equally as complex housing policy space. And that is such a key piece that is missing right now. We have really, really strong Medicaid policy experts, both in state and also contracting with us, but that housing piece is really missing. And then we have great housing experts that can't speak Medicaid at all. And we're going out to RFP to try to find someone who can speak both languages and help us navigate that program. We know that they're out there. Other states have set up permanent supportive housing services before us. Virginia is a model that we're looking at really closely and working with some of their consultants to develop this program. We're also working really closely with the Office of Economic Opportunity to make sure that we don't want to reinvent the wheel. We want to leverage everything that's already out there, but we want to make sure that it's more coordinated and that we're really taking advantage of existing infrastructure and building on that with Medicaid funding.
Great, thank you.
Yeah.
Go ahead. Thank you, Ashley. Alyssa?
I just had a question on this slide. Can you explain or go over the upper payment limit under number 2?
Yeah. So federal law says that Medicaid cannot pay more than Medicare pays for any category of service. And the categories of service are really broad. It's like inpatient hospital, outpatient hospital, nursing facilities. And so on an individual code level, federal law allows you to pay more for a particular service in Medicare than a particular Medicaid service. but on aggregate, it has to be less than Medicare. And so this waiver provision allows us to actually pay more for a particular category of service than Medicare would pay. It's something that is not available to fee-for-service states. It's only available for managed care.
Is that new in the,
It's new since 2017.
it's 2017? Okay.
And it's needed. Without that, we would not be able to pay Brattleboro Retreat anywhere near what we're paying today. Our inpatient hospitalization upper payment limit has been far exceeded as a result of the Brattleboro Retreat payments.
Is it only for certain types of services?
It's for those 3 services that I listed. So inpatient hospital, outpatient hospital, and nursing facility.
Okay.
Great. Any other questions? Got a lot of Medicaid today, this week, which is so important. Joe?
It was just inpatient hospital, outpatient hospital, and
Nursing facility.
nursing. Thank you.
Leslie?
How big a document is this waiver? Is it hundreds of pages?
Yes.
Hundreds of pages.
Yes.
Is there an executive summary?
You know what?
We have some summaries.
And I will say, you can send it to the copy room and they will copy and bind it for you if you want to read.
No, but I wouldn't want to waste
So,
anybody's time or paper.
What I'll do is I was gonna send my issue brief,
Yes, which is
which is a Global Commitment 101, and then an update on the new waiver. I'll send a link
That'd be great.
and you can just look at it online. I'll
That'd
send
be
you the
perfect,
link to
yeah.
AHS. and you
I'm
can
just
read it.
interested in executive, a summary.
Yeah, the summary that Nolan did was excellent, so
Well, I need a review. I probably saw it, but that was a long.
I'll send you all 3.
Thank you.
great. What else? Anything for Ashley or Nolan? Ashley, thank you so much. I do want to say one thing. I forget when last session, but at some point there was real fear in this building that our negotiations on a waiver were going to really reduce the support from the federal government. And what came out of it with the great work of everyone who negotiated with the federal government is really amazing. So over the course of the session, we'll learn more about what else we can do because of the global commitment. But Ashley, I just want to applaud you and everyone else that was involved in the negotiations, because it's pretty exciting what Vermont is now going to be able, how much more Vermont is going to be able to do.
Thank you. We're real psyched.
Yeah. Great. Thanks, Ashley.
It's just a really minor detail, but why the term global commitment? When it's a state by state?
That's a good question.
New, whatever.
The full term of it's Global Commitment to Health. And I don't know the history of it, other than that's the name of the agreement. When they put the agreement, they said, we're making a global commitment to our health.
Okay, but does every state call it that?
No, every state can call it what they want, and I'll call it anything.
Yeah.
I don't, the initial agreement was 2005, and I got here at 07, so I missed that boat.
That's like I make fun of St. Johnsbury's Maple Festival. It's called the World Maple Festival. I was like, come on, guys, we're just one town. That's okay.
That's just our name.
Yeah, that's the Vermont's name. Chosen.
Actually, I'm glad you asked that question because I thought it was named the same in every state. So I did not know.
No.
Oh,
We used to
no.
have we used to have a second waiver called Choices for Care.
I remember that.
And now it's under Global Commitment. The name of that waiver was Choices for Care,
Right.
which was separate from Global Commitment. So we just give them names.
Just to distinguish them, but yeah, but the name it's not quite global.
So if you say one
State by
state's
state, it's an
waiver
11
name,
waiver.
in one state's waiver name.
Yes, it's a great joke. It never gets old, does it?
A new joke. Still have one question, Topper.
Actually, the savings that you talk about that go into investments and all that stuff, where do they come from mostly in the budget? Do they come from services that,
So again, I think this would go to what Ashley was talking about with the fake math. It's not that we can pinpoint it. It's more like we look at the total cost of what
Money that's
all
not
those things spend versus what we thought we would have spent. But it's all negotiated and not truly. So I don't think you can pin, so well, we've got 3% savings
Yeah.
there.
what we do basically is we work with very fancy actuaries to say, what would it cost if all of these people were in a nursing facility? Okay, great. These people aren't in a nursing facility, so that's savings. What would it cost if we didn't manage pharmacy benefit, if there were no prior authorizations or reviews or preferred drug lists? That's what the pharmacy benefit would have cost. Okay, but we do those things, so the delta is savings. That's kind of the exercise where you go through, and if it was a laissez-faire Medicaid program and you did absolutely nothing to curb costs, what would it cost? And then every activity that you do to curb costs, you get to kind of put into savings. And there's a whole complicated, there are lots of things about that where you only get 5% of your savings of the last 10 years and you can carry forward only the previous 2 years. And I mean, it's so complicated, but that's kind of it in a nutshell.
There's mud.
Art?
Well, so to follow up on that, is it actual real money that can be used, or is it just kind of showing us what we saved?
I'm so glad you asked that question because I forgot this point. It is actual real money we can use on the federal level. We have to come up with a state match. And so when we talk about savings, it's savings so that we can bring in more federal dollars, but we still have to come up with the general fund. And so, we'll come in, I'm sure, later this session and we'll show you, we have this much money we can spend on investments. Theoretically, the feds would match that, but we're not going to have, $200 million in general fund to be able to draw down the maximum federal spend. So thank you for asking that. And I really should say that earlier on that, we do need the state match.
Okay.
Joe?
Is it fair to say the savings are fake and the money is real? Because that's what I feel like I'm hearing.
I think it's fair to say that it would be a lot more expensive if we administered this Medicaid program differently than we
Right.
Okay.
And remember, the underlying concept is that it's budget neutral to the federal government. So it's supposed to be equal within, the total spend is supposed to be the same.
All right. Thank you, Ashley. Thank you, Nolan. Have a wonderful rest of the day. And we're done here. So everyone, there's 4 at 3 and we'll see you
Ashley.
tomorrow at 9.